Great. Hello, everyone. My name's Liam Spicer from EMDR Integrative, and I am very honoured to be here today with Professor Paul Miller and Professor Derek Farrell. They'll both be speaking about working with complex trauma, schizophrenia, psychosis, and dissociation. And we're going to be discussing as well the upcoming training that's going to be in Australian-friendly time, which is coming up 31st of August to 1st of September. And just get a little bit more understanding about what's going to be covered in the training, but also as well learning a little bit from Paul and Derek today about working in this area. So thanks, Paul and Derek, for joining me.
Thank you. Yeah, nice to be here.
Thanks for having us.
Yeah.
So just throwing it out, just as a bit of a starting point, just for people out there that might want to learn a little bit more about this area in sort of preparation and lead up to the training. For Paul and Derek, why is a trauma-informed model important in assessing and understanding complex presentations, including psychosis?
I think starting with, because the other model a lot of people will be aware of, Liam, will be the medical model. And so I think what I tell people, first of all, is when I started off in research, it was in psychiatric genetic epidemiology. And that's very much embedded in the medical model. So I worked as a part of Professor Kenneth Candler's team looking at schizophrenia and poor outcome schizoaffective disorder, which Candler felt were the same thing at that stage. And that was really looking at DSM-3R at that point. And that team went on to identify the first gene of risk for schizophrenia. However, what we find with over a decade of research and really looking at the medical model and looking for abnormalities of genetic code, we really, whenever we find abnormalities, actually they were right across all mental illnesses, and none of them have led directly to any particular treatment. So I think that what that began to do was then sort of shine a light on the importance of how the environment affects our genetic code, and indeed how actually we can have an entirely normal genetic code, but yet have a DSM diagnosable illness. So for me, that led me very naturally in my professional journey from really leaning into the medical model as having utility to actually leaning into the trauma model, which led me then to EMDR.
Thank you, both. It seems like there's been a really big transition over the years based on research from a sort of more medical to more trauma-informed model of viewing sort of complex trauma and psychosis.
Yeah, I think it's interesting the fact that sort of Paul and I's take on it, coming from both a traditional psychiatric background and a psychology background, is the fact that actually it gives you an opportunity to look at the landscape in a very, very different way. You know, and it's interesting when you look at the medical legal diagnoses around schizophrenia, for example. But I guess a trauma-informed model would actually see the diagnosis itself is important, but the diagnosis itself is a consequence rather than the issue itself, really, in that sense. And we've always known from looking at clients from an adaptive information processing model, the fact that in itself is a transdiagnostic framework. It actually sort of encourages people to look across the lived experience, of which we know, psychosis, schizophrenias, dissociation, levels of complexity are often the consequence of not just one lived experience, but often a culmination of lots and lots of different experiences. So the element of psychosis is massively important on one level, but it's only part of the narrative on another level. And really, just echoing with what Paul is saying, is that we also know that we're living in an occupation and environment where lots of people with psychosis, lots of people with schizophrenias are being viewed through one lens. Particularly on the international scale, where we know that sort of biological models are predominant. And it's not to say that the biological models don't have something valuable to contribute, because they do. But I think in order to understand the complexity of people's lived experience, we need those broader frameworks. And I think the AIP model within EMDR, I think, gives us a really nice conceptual map that we can use. So in the course of the 2 days with Paul and I, what we really want to do is deconstruct a lot of those elements. So looked at people's lived experiences through many different lenses, but ultimately it's always got to come back down to, well, when you're in the room with the client, what are some of the additional perspectives, some of the additional skills that you can be using for when you're working with these vulnerable populations?
Yeah, and to pick up on that, what Derek and I will be covering is one of the most important things is hope in the therapeutic model. For a long time, I've really felt that the medical model for, in particular, schizophrenia and psychoses, but also I think for complex trauma, you know, I would be seeing a lot of people from a law enforcement background, and the language would be these individuals maybe in their early 50s are medically retiring and basically being told this is as good as it gets. And so really there's a lot of therapeutic nihilism, and we see that in psychosis as well. However, when we actually look at a trauma model, and actually the trauma model is a renaissance of that model, because the trauma model for psychosis existed right at the start whenever Bloiler wrote his textbook about the schizophrenias, giving us the term. And so whenever we look back on it, trauma and dissociation is right at the center of it way back then. So it is a renaissance of that. But the key thing is we need to, as therapists, inform ourselves how to talk about that with clients, because often many clients are coming having taken on board the message I'm biologically broken, which isn't actually true. And so we would say, as the trauma model says, AIP for us as EMDR clinicians, it tells us that you're understandably disordered given the set of extreme circumstances. So knowing the knowledge, the summarization of the research that's out there, some of the different models Derek and I will talk about, instead of getting caught up in these questions such as, is this complex trauma, or is this psychosis, is this dissociation, or is this psychosis, that instead we shine a light on models that actually bring utility to the psychoeducational part, and then we'll look at how they then lead on to working in a therapeutic way. And Derek and I will be covering then sort of practical ways that the trauma-focused, trauma-informed model will actually then allow us to guide case formulation as it then links into treatment. So rather than it being us teaching a protocol, what we'll be teaching instead is case conceptualization and case formulation, and then allowing that to guide then how do we find the pathogenic memories that we want to be targeting.
For sure. So it sort of really brings in that ARP as a framework, and is really sort of integrative in nature in terms of the approach. Regarding sort of complex trauma and psychosis, from both your experiences, is there much difference with other trauma-based presentations, and what are the differences that you guys have both observed when working with these populations?
Well, I suppose many of the psychological frameworks that are used in the treatment of psychosis predominantly fall within the cognitive behavioral psychotherapies. In that sense, which we know is an interesting model. It very much focuses on extinction and sort of habituation of people's sort of lived experiences, really. As you know, with the AIP model, that's looking at that from a different through a different lens. In that sense. I think one of the other things that I suppose that we've learned from sort of other studies is the fact that an awful lot of interventions tend to focus on the individual. And what we're learning is the fact that actually that in itself creates lots of problems, because actually the individual experience is informed by the relationships they have, that they have around them. So, for example, we've been doing a study looking at sort of death by suicide within military veteran populations. And actually, one of the consistent things that comes out in those studies is the fact that it's how services actually don't match the needs of clients, or they focus on behavioral components of the client's lived experience rather than looking at the broader perspective. So when Paul was talking before about some of the essential psychoeducational aspects, particularly within psychosis, those psychoeducational frameworks are not just for the client, they're also for the partners and for the family and for the wider mass nations. And that's one of the challenges that I think the EMDR community also needs to address, is the fact that sometimes it can be very insular in its viewpoint. It only really focuses on the client that's in front. But actually, we've got to look at some of those more broad, more systemic sort of approaches to care, really, in that sense. And so, yeah, just to clarify, what we're saying is that the AAP model is important, but we also need other maps. We also need other considerations as well, really, in that sense. And actually, one of the other interesting maps, well, there's two maps that probably informed Paul and I the most in our work. One is some of the work around Marius Rom, which was a great contributor towards sort of social psychiatry, particularly in relation to sort of voice hearing. And then the second one is the work of Ian McGilchrist, really talking about not just about the distinctiveness between sort of left hemisphere and right hemisphere information processing, but something about the synergy about what happens when they when they come together.
Yeah, and I think that's where the real utility that Derek and I have found comes, because what's really been very powerful for us to see is how well the work of Francine Shapiro and other people who went on to develop the AIP model, Roger Solomon, etc. And we look at how AIP is now actually linking in really strongly with what we're learning about the neurobiology and how that functions. And so we have sort of, in a sense, some of initially the view, as Derek has said, being focused on what is happening in an individual neurobiology, but actually what we're really hearing now is people like Dan Siegel picking up and following the work of the late Jaak Panksepp, looking at then the work of Alan Shore, talking about how we need to move from an individual neurobiology actually to an interpersonal neurobiology, because that's how we exist. We exist interpersonally. And Uri Bergman, who's written the book looking at summarizing neurobiology for us as EMDR clinicians, again, in that excellent book, now in its second version, reminds us that we create an energetic system between the two of us. And actually, that's what modern neurobiology is telling us. It's not just and can't fully be understood by us looking and considering what's happening within our client, but we have to consider what's happening, in a sense, between us. And that's really important. So we'll talk a lot about that, and linking in Ian McGilchrist's work, looking at how not the old-fashioned sort of that the right hemisphere is the creative side and the left is the logical side. That's not true. But looking at his modern evolution of split brain theory, we'll be looking at how that can help us with regards to case conceptualization. The role of one hemisphere is to inhibit the other, but if it's unopposed, then we get problems. And much of the problems we see in these complex disorders is due to a lack of functioning in the right hemisphere, which means the left is unopposed. And so we'll talk about what that means for treatment planning, and then look at some of the evidence for that and how we could practically use it.
There's going to be a really great emphasis on AIP, but also Ian McGilchrist's work and other paradigms like interpersonal neurobiology, and also as well what you mentioned earlier on. And another thing that's going to be sort of focused on within the training is the power threat meaning framework. Can you briefly explain a little bit about that sort of framework in terms of psychosis and complex trauma, and how that sort of helps our understanding of things?
Again, it's a model that one of my colleagues and supervisees, Susie Colbert, introduced me to. And I think it's the BPS have developed the model. So again, it's a model that we'll be talking through with people that, again, is helping to give them a different framework, which is different to the medical model. So again, it's very much a trauma-informed model as I understand it. And I think one of the most important pieces for me when I look at it is that we're saying to people that these things, these experiences, these phenomena, that they have meaning, that they are an attempt to adapt, and that we can understand what they're adapting to and the forces involved there by looking through the lens of power and threat. And I think that that's a very hopeful message for people, because now you aren't hearing voices or you aren't experiencing these terrible visual hallucinations because you're broken. It's actually your system attempting to adapt to it. So I think it's a very powerful model. I think it's one that has real utility, and it actually makes a lot more sense than what we're currently looking at from a purely medical model, which is really just a collection of symptoms. It's just a presentation of a syndrome. And so I think it's a model which really advances case conceptualization. And for us as trauma therapists, it's completely aligned with AIP in my mind.
Yeah, and I think there's an important sort of synergy between the AIP model and the power threat meaning framework, because they are transdiagnostic perspectives. But I also think there's a third one, which is part of the triad, really, which is the importance of compassion, which is about the fact that actually sometimes the lived experience is, that can't be changed, in that sense. And so it's finding a way of being able to assimilate the lived experience in a way that is potentially transformative, that is reinventive, in that sense. And so this is why we come back to the fact of, we do think the AIP model is a very, very useful conceptual framework, particularly in regards to treatment planning and giving people maps as to how to move forward. But we do think that there are some other very useful models that could be very, very helpful, particularly when we're working with client groups of greater levels of complexity, greater levels of vulnerability, and greater levels of of sensitivity. Because what we know from the literature is that the greater the complexity of the needs for the client, the more bespoke the intervention needs to be, in that sense. And so, this is why we know that for PTSD, it's very easy to manualize treatment. But actually, when we get to clients with much greater levels of complexity and vulnerability, it's much harder to manualize it, really, in that sense. And so that's why looking at that broader array of material is really important for Paul and I.
Yeah, and I think the thing that comes across, something I know Derek has taught a lot about and is very involved in as a sort of international humanitarian, is the work of looking at the sociological and the anthropological context, because again, we see and we know, again, we're told of the traumatizing effect of poverty, the traumatizing effect of internal displacement by conflict. And so when we look at these different factors, as Derek's saying, we need tools to help us, but we can't actually just rely on a protocol, because they're no longer sufficient. But that doesn't mean that we are without a guide. The reality is our guide is what Derek has been talking about, what we've been mentioning in the questions you've asked as well, Liam, that we actually have these very, very valuable frameworks. And so people being able to have a framework which allows the bespokeness to happen, and yet it is just as equipping as a protocol. And I think once people start to realize that, they don't go to the question of what is the protocol for this, and instead they see how well equipped they are by these transdiagnostic formulations and ways of understanding. And looking at things internationally, we can, certainly we come, I think, within the United Kingdom of a model that is still pretty driven in terms of things like schizophrenia with a medical model. However, it's not always the case. When I was teaching in Argentina, the work of Melanie Klein remains highly influential there. And whenever you have somebody with a diagnosis of psychosis or schizophrenia, they are offered both psychotherapy and medication as a model of treatment. So there are these wonderful models that exist around the world. We have up in Western Lapland the models of open dialogue, and we'll be talking about these different international experiences, which gets results of people. Over 75% of people return to work or education after 3 years of their psychotic episode, many of them being medication-free at that time point. I mean, we just simply can't compare with that output in terms of our current models. We look at the models of individuals treated with psychosis on treatment of choice with antipsychotic medications, and we compare that with countries where those medicines aren't freely available and therefore don't tend to be offered, and we see better outcomes in Africa where those medications aren't available compared to here, and it raises questions of, are we using them in a safe way? So there's lots of things that we need to look at and can inform our debate, and we'll hope to try and bring in those different things to hopefully make it interesting.
Sure. So it seems like there's been a real big shift in not only theory, framework, but also research in recent times, but there's still, I guess, a long way to come in terms of integration of practice. As just one simple example in terms of this sort of whole integrative trauma-informed approach, borrowing from these different frameworks and models, when a client's experiencing maybe symptoms like voices as an example, how would you sort of view things from this sort of integrated approach?
Well, the thing that, if you think about the last sort of, 60, 70 years, the understanding of voice hearing has changed really quite dramatically from a traditional biological approach, which was that, if a client admitted to voice hearing, the intervention was usually increasing their psychotropic medication, really, in that sense. And often what clients learned is don't disclose that you're hearing voices. Type of thing. And so you got into this situation where the fact that, well, because clients then didn't disclose that they were hearing voices, that was then seen that the medication was then effective, in that sense. But people are actually just doing what they need to do to survive, really, in that sense. You know as well as I, Liam, that one of the really useful protocols within EMDR is the flash forward, which really looks at the catastrophic sort of components of people's worst fears, which we know drives things like phobias and drives things like OCD, but it can also drive psychosis. In terms of some of the voices that people can hear can be highly distressing, can be highly content rich in a way that raises very, very profound levels of effect. So one of the beauties of the social psychiatry model is that it really sort of it was really requested mental health practitioners to, instead of to ignore the voices, but to actually give them voice, to give the voice voice, because if we think about the way in which we work with phobias, which often has sometimes a very distinct traumatological link, so it's about going back to those earlier experiences and processing those, but sometimes those voices are based around worse fears. They are based around sort of particularly horrific sort of future orientated sort of concerns, really in that sense. And so as Marius Rom says, it's much better to give voice to the voice hearing than to ignore them, because the voice hearing itself is part of the person's lived experience. Paul, anything?
Yeah, that's really important. And I think just to pick up on another thing that Marius Rom said, again, he and his wife Sandra Escher, with other people within the Hearing Voices networks, they've examined internationally trauma burden and then these experiences that we categorize often as psychosis, and not only have they found a relationship across each country internationally, but they find that dose response, that the greater the trauma burden, the greater the risk. But I think one of the things that just really stands out for me listening to Derek there as he's talking about Marius Rom is Marius reminds us that, we're a binary species, 2 eyes, 2 ears, 2 hands, and we tend to think 2 options for things. So what do we have? We have well people who don't hear voices, and we have sick people who hear voices. But one of the things that he commands us to do is to look at actually there are well people who hear voices. And so I think that's one of the things that it's important as we begin to formulate these things, and as we'll talk about in the presentation, many of the things that people hold on to as fact are actually derived from philosophical positions that were taken over 100 years ago, largely, for example, by the work of Karl Jaspers, who said neurosis is psychologically intelligible, but psychosis is meaningless. It can't be understood logically or in a format. It's broken noise from the brain, and that meant for over 100 years we've ignored, or some people have ignored, the content. But actually now, whenever we see that when we pay attention to that and give voice, that actually there's real meaning there, and also that there's an attempt to adapt. And we'll talk a bit about the different models for working with voices and parts as it sits within dissociation, and looking at the work right from C.G. Jung's work with active imagination. We'll talk a bit about Hal and Sidra Stone's work in voice dialogue, and then but would lead us through the structural dissociation model of the personality and such like, and give people examples where there's potential utility, but what it all comes down to is that these phenomena have meaning, and not only do they have meaning when we listen and do what Derek is advising in terms of the bespoke nature of our interventions, actually we can make real change with the person. And that's one of the things that the open dialogue approach talks about, be with, not do to, that this and what we're going to be presenting is not something that you're going to be able to, like some great magician, do to your patients and make them better. It's more the dynamic we're going to talk about, how you can work with the person sitting in front of you and help them to make that therapeutic journey.
Certainly. There's going to be a really strong relational focus, theory, frameworks, research, conceptualization, but also various techniques and other sort of approaches. Is there anything else just to finish off that you guys would like to mention that will be covered in the training, or why people should come along to this important 2-day training on complex trauma, dissociation, psychosis, and schizophrenia?
Yeah, just a little note of caution for our our colleagues, really, because we're going to be working to Sydney time. It means that Paul and I will be working through the night. So Paul and I will be having copious amounts of coffee. So we might be a little bit sort of caffeine rich and a bit hardwired by the time we get sort of there like a meerkat.
Yeah, be gentle.
So no, but listen, the best learning is learning that's informative, but involves relationships and good humor, in that sense. And so we'd be delighted for people to come along, but yeah, very much looking forward to it.
And I think to pinch something which I think I heard Derek say the last time, is whenever we're presenting, there's going to be a lot of stuff, okay, and we hope people will be excited by that, and also that they'll be interested to follow what the pathways that are relevant to them, pick up the threads that are of interest. But one of the things that Derek had said the last time, at least I'm going to say it was you, Derek, I think it was you, but it might not have been you, but I'll say you said it anyway. But one of the things was that we're going to present stuff that will be new for people, and so people will hear new stuff. And for other people, the stuff that we present won't be new, but we want to invite people to hear those things in a new way. And I think the new way that we want people to hear these things is through the lens of hope, that these are not the severe enduring mental illness, that these terminologies of therapeutic nihilism, the sense of complex trauma being something that's an end point for people and only palliation is possible. Because that's not true. And I think, even in these individuals, small things are not trivial. So small changes that may be achievable, about looking at those. And we'll touch upon the whole range of things. And we'll mention pieces that are informed from research, and also hopefully shine a bit of a light onto the hope for the future that also involves sort of options which we're seeing coming down the line, which include things like the psychedelic medicines and include things like stellate ganglion procedures, and how they can actually be really facilitatory in terms of the work that we're going to talk about as a trauma-informed transdiagnostic approach.
Yeah,
Certainly.
and just to give colleagues a bit of an insight into the way Paul Miller works, he'll say, well, look, I've got 3 really important points to make. And the 5th one is... Tell me I'm wrong.
A lot of deep learning, but a sprinkle of fun and humour is what we've got in store by the looks of it.
Yeah, definitely.
Very much looking forward to it. So yeah, if you want to come along to the training, spots are still available. It is going to be 31st of August to 1st of September, 9 a.m. to 4 p.m. Sydney, Melbourne, Tassie time, Australian Eastern Standard Time. That will be on Zoom. So hope to see you there with Professor Paul Miller and Derek Farrell, and reach out if you have any questions in the meantime. Thanks for joining me today, Derek and Paul.
Great.
Thank you.
That okay?